Alrighty, so today we'll be going over some vitamins and then a little bit about colorectal cancer and strep bovis at the end. So we'll just go ahead and get started with our vitamins. Alrighty, can anyone name me the fat-soluble vitamins?
A, D, E, and K.
Correct. A, D, E, and K. And these are dependent on the gut and the pancreas for absorption. Does anyone know why toxicity for these guys is more common than for water-soluble vitamins?
Because we hold on to them.
Right, and where...
Like our fat holds on to them.
Yes.
For longer periods of time.
Correct. They accumulate in the fat and they travel in the blood with albumin, so they're in our system longer. Then we have some malabsorption syndromes that can cause some issues with these vitamins here. Can anyone name some?
CF, Crohn's, celiac.
Yeah.
Celiac.
Yes. So first aid mentions cystic fibrosis and celiac disease, but so on and so forth. Awesome possum. Okay, so now the water-soluble vitamins. You guys can name these guys?
A bunch of B's.
Everything else.
And a C.
Sounds like a report card.
Ooh.
Yes. Bunch of B's and a C. Specifically, these guys. All of these usually easily wash out from the body, except which two?
B12.
Yeah, B12.
And B9.
Correct. B12 and B9. So B12 and B9 are both stored in the liver. How long is B12 stored for?
A year.
Couple years.
3 to 4 years. And how long is B9 stored for?
Couple months.
6 to 9 months.
3 to 4 months.
Hold on.
But close though, in the month range. So you got years for 12, months for 9. 12 is bigger than 9, so if that helps somehow, that's there. And if we have general deficiencies in B-complex vitamins, what do we usually see? 3 specific things.
Glossitis.
Mm-hmm.
Diarrhea.
Mm-hmm. And one more thing.
Megaloblastic anemia. Peripheral neuropathy.
Those are specific to certain ones. More general.
Okay, so general. Skin problems. Dermatitis.
Yeah, correct. We have dermatitis, glossitis, and diarrhea. Cool. Now we get to do the fun part of going through each of these. Woo. Okay. So our vitamin A is otherwise known as retinol, is an antioxidant. It's absorbed in the intestines. Let's see, this is important for normal differentiation of epithelial cells into specialized tissue. Anyone know what it can be used to treat?
Measles.
And?
APMO.
Yes. Correct.
And burn patients. And something else. But are you looking for more?
Acne.
Acne, right. Yeah.
That would be the next one. You can use oral isotretinoin for severe cystic acne. And then another version of vitamin A, all trans retinoic acid, is used to treat
APO.
Yes.
APO.
Nice. So, if vitamin A is essential for differentiation of cells and all of that fun stuff, what can we see with a deficiency?
Night blindness.
What else?
I don't think first aid highlights this, but vitamin A is a cofactor for PTH. And so if it's not a cofactor, if you're deficient in vitamin A, then you can possibly have hypoparathyroidism. Just throwing that out there.
Interesting.
Good to know.
I learned that from past, so that's my resource.
Oh, cool. Okay. Got any other symptoms of deficiency other than night blindness? Anybody wants to throw out there?
Decreased CSF.
I heard decreased CSF. First aid does not mention that one, so I'm not sure about that one.
Dermatitis.
Okay, kind of.
APML thing? I don't know.
Well, it does affect your skin, so you will see dry, scaly skin, known as xerosis cutis. And then you also can see corneal degeneration in addition to the night blindness specifically. And immunosuppression. So if your cells aren't differentiating, that could be a problem. And then with too much vitamin A, you can have generally nausea, vomiting, vertigo, blurred vision acutely. Does anyone know what kind of things you'll see chronically?
Pseudotumor cerebri.
Boom, that's a big one. And let's see if you guys can name 2 more things for me, at least. I don't know what organ it might be toxic to.
Liver?
Yeah. Yeah, so you will see with chronic toxicity, you'll see hair loss, dry skin, hepatotoxicity, /enlargement, arthralgias, and pseudotumor cerebri. And this is teratogenic, so what is required before isotretinoin can be prescribed?
Woman needs a beta-HCG test.
And or birth control. Or consent.
Well, so you need a negative pregnancy test and 2 forms of contraception. Nice. Okay. On to our next vitamin, B1.
Real quick, sorry. The reason why vitamin A is you can use for measles is that it regenerates the epithelium of the lung quicker to get the infection out. So that's why.
Okay.
Good to know. Alrighty. Vitamin B1, otherwise known as thiamine, found in grains, meats, and legumes, is a cofactor for several dehydrogenase enzyme reactions. Can anyone name some of these reactions?
PABT, so pyruvate dehydrogenase, alpha-ketoglutarate dehydrogenase. The T is transketolase, and the B is branch chain amino acid dehydrogenase.
Keto acid, but boom on all the other ones. Awesome. So
Nice.
Keto acid. Oh, got it. Okay.
Keto acid, yes. Awesome. Well, they're shortening me on my questions. All right. So with a deficiency, you will have impaired glucose breakdown, you'll have less ATP available, so the highly aerobic tissues like the brain and the heart are affected first, and you'll see an increase in lactic acid. And the most common cause of deficiency of B1 is alcoholism, because alcoholism prevents B1 uptake in the small intestine. And one syndrome of particular importance is Wernicke-Korsakoff syndrome. Can anyone name me the classic triad for the Wernicke portion?
Confabulation?
That's for the other one. So we'll hold on to that one.
Yeah.
Confusion.
Confusion is one.
Ophthalmophagia?
Yeah. One more.
Starts with a T, doesn't it?
Starts with an A.
Aphasia?
More about how you're walking.
Ataxia.
Yeah. So classic triad, confusion, ophthalmoplegia, and ataxia. And then the Korsakoff portion, Tulsi already mentioned confabulation.
Gotcha. Yeah, confabulation.
Memory loss.
Memory loss.
Personality changes.
Boom.
No long-term memory.
Personality changes.
Yes. Yes to all three. Fabulation, personality change, and memory loss, which is permanent. And of course you have your dry beriberi and wet beriberi there as well, with wet beriberi having the dilated cardiomyopathy syndrome. That's what your differential there is. Yeah, and there's also a risk of HIV with decreased vitamin B1. Throwing that out there. Yeah. So, any questions about B1? Comments, concerns, things to add?
The whole idea about why you should give before you correct. Before you correct their I'm trying to say, if you have a patient who is
the one there where it says alcohol or malnourished patients give thiamine before dextrose.
Yeah, and you want to give them B1 before you correct their glucose levels, because they're in lactic acidosis without the B1. And so you correct, or you do the B1 so then they can stop using the glucose that you're about to administer as a lactic acid, like anaerobic anaerobic. I don't know if that makes sense.
Yeah, that makes sense.
No, you're right, because of the enzymes that it's a cofactor for pyruvate dehydrogenase. If the glucose that you're correcting isn't able to enter TCA cycle, is going to enter more lactic acidosis. So you're just going to further that.
Yeah, exactly what I was trying to say.
Ooh, biochem.
Okay. All right, on to our next one. Vitamin B2, otherwise known as
riboflavin.
Yeah, riboflavin. So, what is riboflavin a component of?
FAD.
And?
Succinate dehydrogenase. No. That's just the connection. FAD and like you mean FAD and FADH, like that?
Well, it is another abbreviation, but it's not FADH.
And no.
It's going to be FAD and FMN. These guys are cofactors in redox reactions, and then their little mnemonic for it is the F's for both of them, FAD, FMN, have the F in riboflavin, they're both flavins. And then your redox reactions, you have B2s, Z2, ATP, all that fun stuff. Well, okay, so knowing that that's what they're important for, what would a deficiency in B2 look like? And then I left the 2 C's of B2 there for
you get angular chelosis.
Yeah. And the other
C?
And
something with the cornea.
Yeah, so you get chelosis and corneal vascularization. whole beans. And B2 is found in dairy products, so I'll throw that out there. And it is also a cofactor for glutathione reductase and tryptophan, so important for another vitamin that we'll talk about a little bit later. Oh, okay. All right.
I have a fun fact. The whole idea about you mentioning that the best source is milk is also the idea of why like our milk is no longer like, or it doesn't come in like glass bottles anymore, and it's like comes in the carton. The carton, like if it's exposed to the sun, it causes the breakdown of riboflavin in the glass bottle, but like in the carton, it like prevents the sun rays entering in and causing like breakdown. So I guess the idea is like back in the day when people got milk, like they would just get them in glass bottles and they would be like put on the porch, and then if it was like exposed to sun, it was going to break down all the riboflavin by the time they drank it. So now we have like cartons.
Fun
and
little
I guess
tidbit.
they're like made in whatever ways to prevent entrance of sun rays.
Awesome. Anything else anyone wants to add for this guy? Okay. Vitamin B3, otherwise known as niacin. This guy is found in liver, milk, and grains. It's a component of NAD and NADP, also used for redox reactions. And this is derived from tryptophan, which vitamin B2 is also a cofactor for. So it says right there, synthesis requires vitamins B2 and B6 to make tryptophan, and then you get niacin from there. So nice little complicated chain of things there. B3 can be used to treat dyslipidemia and lower levels of VLDL and raise HDL, so woot, awesome. With deficiency, you can see glossitis general for the B complex vitamins. With severe deficiency, it can lead to pellagra. Will anyone tell me what the symptoms of pellagra are?
Diarrhea, dementia, dermatitis.
Correct.
And death.
Yes. And death being the fourth D. And pellagra can be caused by Hartnup disease, where you have a decreased availability of tryptophan for conversion to niacin, and it's an autosomal recessive deficiency of amino acid transporters. So, fun, not so fun stuff there. Can anyone tell me what an excess of vitamin B3 might cause?
Itchiness and redness and flushing.
Yeah, that's there. And then if it's supposed, okay. Also, since it is used to treat dyslipidemia, if you have too much of it, you can cause problems related to that, as well as hyperglycemia and hyperuricemia. And when you are treating a deficiency of vitamin B3, you would treat with both vitamin B3 replacement as well as tryptophan replacement also. Anyone want to add anything for this one, guy? Okay. B5, pantothenic acid. I'll be short on this one. Does anyone know what this is used for?
Coenzyme A.
Correct. Essential component of coenzyme A and fatty acid synthase. So, for example, you have pyruvate and coenzyme A coming together, you got acetyl-CoA, and then you have that going on to your TCA, fatty acid synthesis, cholesterol, and ketone body synthesis. A whole lot of important things. Deficiency with dermatitis, enteritis, etc., adrenal insufficiency, all of that stuff there. And then we have pyridoxine, which is a cofactor used in transamination. Well, it's converted to a cofactor used in transamination reactions. Can anyone tell me what a deficiency in B6 would look like?
Hepatic deficiency, yeah. Peripheral neuropathy and hepatic dysfunction.
Yeah. And you see a particular type of anemia?
Megaloblastic.
Sideroblastic?
Oh, yeah, sideroblastic.
Sideroblastic. Yes. With convulsions, hyperirritability, peripheral neuropathy, like you guys said, and sideroblastic anemia because you have impaired hemoglobin synthesis, since this guy is important for synthesis of heme and all of that other stuff listed up there. Can anyone name me some drugs that can inhibit vitamin B6?
Isoniazid.
Yeah. Anyone have any other ones? So there's also cyclosporin and penicillamine will also inhibit vitamin B6. And this guy can be found in meat, egg yolks, and wheat. So toss that little tidbit in there too. Anyone want to add anything for these two? No? Okay. So then we have biotin, also known as vitamin B7. It's a cofactor for carboxylation enzymes, which add one carbon group. There's some examples there for you with pyruvate, oxaloacetate, so on and so forth. So, deficiency here is relatively rare. You'll see dermatitis, alopecia, enteritis. Does anyone know what the deficiency is caused by?
Something about egg whites, avidin.
That's one reason. There's another one.
Antibiotic use?
Yes. So deficiency can be caused by antibiotic use or excessive ingestion of raw egg whites. And like Tulsi said, there's avidin in egg whites, which binds up the biotin, so can't use it for what we want to use it for. Anyone want to add anything to this guy? Nope. Okay. So then we have folate. Woo, important guy here. This is converted to tetrahydrofolic acid, THF, which is important for also one-carbon transfer reactions as well as methylation reactions, and also important for the synthesis of DNA, RNA, all of that stuff. Found in leafy green vegetables or fruit. It has a small reserve pool that's stored in the liver. Anyone know what a deficiency of this guy would look like?
Megaloblastic anemia.
Mm-hmm. And what?
You won't see any neurologic symptoms because it's not B12.
Yes, we won't see any neurologic symptoms. Do we know what lab values we might see special to this guy?
I don't know. You do see the homocysteine methyltransferase in the urine.
Correct. So you see an increased amount of homocysteine. Cool. And this is the most common vitamin deficiency in the United States, so a fun little tidbit there too. And a deficiency in folate can also be caused by several drugs. Can you guys name any?
methotrexate.
Yeah, methotrexate is one.
Sulfonamides?
Mm-hmm. There's a seizure drug.
Phenytoin?
Yes. Phenytoin, sulfonamides, and methotrexate can cause a deficiency here. And then we also give folate supplementally to mothers at least 1 month prior to conception and during early pregnancy to prevent what?
Neural tube defects.
Yes, to decrease the risk of neural tube defects. Awesome. Anyone have anything to add for this guy? Nope. Okay. On to B12, the last of our B vitamins, and we're nearly there. This guy is a cofactor for methionine synthase, and is important for DNA synthesis, found in animal products, etc., etc. Does anyone know what a deficiency in B12 would look like?
Also megaloblastic anemia.
Also megaloblastic anemia. And what differentiates this from a B9 deficiency?
So the neurological defects.
Yes.
And then in lab values, you would see homocysteine, methyltransferase, and methylmalonyl-CoA mutation, I think.
Close. Yes. So, very similar to B9, except like you said, there's also neurologic symptoms like the subacute combined degeneration, and then you do have serum homocysteine levels being increased as well as methylmalonic acid levels being increased. And in fact, you can also have a secondary folate deficiency with this guy too, so that's another tidbit in there. Anyone know what deficiency in B12 can be caused by?
Crohn's disease?
Caused by Crohn's disease.
You have a oh god, what the hell's the other one called? Parietal cell autoimmune disorder? Or no, I'm thinking.
You're talking about intrinsic factor?
Yeah.
Yeah. Pernicious anemia? Isn't that what was it?
Yes.
Anti-intrinsic factor?
Yes. There's another category, but I'll give it to you guys. You have malabsorption with examples sprue or that organism there, or lack of intrinsic factor, like you guys said, with pernicious anemia or gastric bypass surgery, and then absence of terminal ileum with either resection or with resection for Crohn's disease. And of course, there's insufficient intake. If you're vegan and not getting this in animal products, is where it's found.
Diphyllobothrium latum.
Which competes for B12, so it wants it for itself and doesn't want to give it to you, so that's where that problem comes from. Does anyone know the name of the test that you can give to test someone for?
Schilling's.
Yes, a Schilling test.
Wow. Good thing you asked that.
Hey, you remembered it, so good.
Yeah.
Okay. Anyone want to add anything for this guy? Nope. Okay. So we're going to leave our B-complex vitamins behind and move on to the rest of the alphabet here. We have vitamin C, which is also an antioxidant and facilitates iron absorption. And what is it necessary for in collagen synthesis? What step?
Hydroxylation of proline and lysine.
Correct. It's necessary for hydroxylation of proline and lysine. and also for dopamine beta hydroxylase. And this guy is found in fruits and vegetables. So there is a condition in which a deficiency of vitamin C is found. Does anyone know the name of that condition? Particularly known for pirates getting it, being on boats for long periods of time without vitamin C.
Scurvy.
Yes. I got scurvy. So what does scurvy look like? Oh, well. Okay. So we have swollen gums, bruising, petechiae, hemarthrosis, all this poor wound healing and stuff going on. Why is this happening?
You have poor collagen synthesis, so it's not going to be able to heal or create decent skin cells.
Correct. And then with an excess vitamin C, you can see some nausea, vomiting, diarrhea, calcium oxalate stones. And what else can it cause an increased risk for related to its function? Particularly in people who are getting transfusions or have hereditary hemochromatosis. So you can see an increased risk.
Go ahead.
Well, you can see an increased risk of iron toxicity with these in predisposed individuals like the ones I mentioned, transfusions and hereditary hemochromatosis, because vitamin C helps facilitate iron absorption. So if you're having too much, you might also have too much iron. Anyone want to add anything for this guy? Okay. Vitamin D is important for increasing intestinal absorption of calcium and phosphate and for bone mineralization and bone resorption dependent on the level. So a deficiency in this guy would cause what in children and what in adults?
Rickets in children, osteomalacia and osteopenia in adults.
Yeah, correct. So you can also see hypocalcemic tetany as a symptom. And to prevent rickets, we want to give breastfed infants oral vitamin D so they don't get that deformity. What can exacerbate a deficiency in vitamin D?
Renal dysfunction. Okay. Not being exposed to the sun, because that helps.
Yes. It's one. Also renal dysfunction, but it's not one that first aid mentions particularly in this sentence that I've hidden here, but that is another one there. And low sun exposure. And there's also pigmented skin and prematurity are the other ones that first aid lists as causes for deficiency. And then with excess, you'll have opposite problems. You'll have hypercalcemia, as well as so much calcium you're peeing it out with hypercalciuria, loss of appetite, stupor, etc., etc. And you can see an excess of vitamin D in granulomatous disease. So that's a key thing to remember there. Specifically, sarcoidosis. Yeah. So, any questions, comments, concerns, things to add for this guy? Okay. So, on to our last two, and then we'll be done with vitamins. Woohoo! Vitamin E, another antioxidant. This guy is important for protecting RBCs and membranes from free radical damage. And is related to vitamin K, which we'll talk about next, because a high dose of vitamin E can alter metabolism of vitamin K and lead to some anticoagulant effects, so it's a little dangerous there. But if we have a deficiency of vitamin E, does anyone know what that looks like?
Isn't it similar to B12, but does not have macrocytic anemia? Or megaloblastic anemia?
Yeah, it is similar to B12.
So this one would have muscle weakness and some sort of demyelination problem.
Yeah, and if it protects your RBCs and you don't have enough of it to protect your RBCs, what kind of anemia?
Hemolytic.
Yes. You see hemolytic anemia, acanthocytosis, and like you said, muscle weakness and neurological symptoms as well. And then, again, like you said, presentation can appear similar to vitamin B12, but without the megaloblastic anemia.
Hypersegmented neutrophil deficiency.
Yes. Correct. So, without megaloblastic anemia, hypersegmented neutrophils, and no serum methylmalonic acid levels being increased. And then we have vitamin K, which is activated and then uses a cofactor for gamma carboxylation of glutamic acid residues for blood clotting. Basically important for blood clotting. And this guy is synthesized by intestinal flora. So, what in blood clotting specifically, what proteins or clotting factors is this guy necessary for?
(10,972) CNS.
Correct. And what inhibits the synthesis of these particular factors and proteins?
What is it?
What drug inhibits the synthesis of these factors and proteins?
Warfarin?
Yes. Correct. So, like you said, factors 10, 9, 7, 2, and protein CNS, and then you have warfarin here coming in and messing all that up, so gotta keep an eye out for certain heme-related levels there. A deficiency in vitamin K can be seen as what lab values?
Increased PT and PTT. Iron.
And what about the bleeding time?
Elevated.
So your bleeding time is actually going to be normal.
Same level.
Yeah. You do have increased PT, increased PTT, but a normal bleeding time. And you also can see neonatal hemorrhage. Why would we see this with a deficiency in vitamin K?
Is it because they don't have vitamin K?
Right, so neonates have sterile intestines and they're unable to synthesize vitamin K. And then in adults, you can also see vitamin K deficiency with prolonged use of broad-spectrum antibiotics, again, because you need that intestinal flora to synthesize this vitamin. So, neonates are given vitamin K as an injection at birth to prevent what condition?
Hemorrhage.
Oh, yeah. Specifically called hemorrhagic disease of the newborn. Well, we made it through the vitamins. Okay, Any questions, comments, concerns about any of the vitamins before we move on to our next topic? Nope. Okay then. Colorectal cancer. Fun stuff there. Okay. So, this is the third most common cancer in both men and women. Most patients are over the age of 50, and about 25% have a family history. You guys name some risk factors for colon cancer?
Polyps.
Polyps?
Family history.
Mm-hmm.
Age. IBD.
Mm-hmm. What about any social
Tobacco.
practices? Yep. Yep, that's pretty much mostly all of it. So you'll see polyps, family syndromes, IBD, tobacco, and also a diet of processed meat with low fiber. Most commonly found in the rectosigmoid, about 50% of colorectal cancers are found there, and then ascending and then descending in order of likelihood of where it's found. So the right side is bleed, so you'll see mostly polyps and fewer overt symptoms and a later diagnosis, versus the left side being obstructive. This is more of a circumferential type of lesion, so you'll see decreased stool caliber, more obvious symptoms to show up sooner rather than the right side. Make sense? Okay. And this guy can also present with a bacteremia. Does anyone know what organism is responsible for? Or, well, yeah. Yeah, correct. Strep bovis. And they also mention Galactolyticus as another specific species to cause this bacteremia that presents with it as well. And so this can be diagnosed with a certain number of things. Normally, if you see a patient who has iron deficiency anemia, especially in a male, that's going to cause a little red flag to go up there, and in postmenopausal females also raises a red flag. So, to help pre-diagnose people, we start screening them at what age?
50.
Yeah, we start screening at the age of 50 with a colonoscopy, and then there's obviously alternatives. You can do a sigmoidoscopy every 10 years instead of doing a colonoscopy every 10 years. You're not doing the full length of the colon, you're just doing the first 2 feet. You can also do fecal occult blood testing or fecal immunochemical testing every year, as well as a CT colonography, but these guys have more false positives and aren't as preferred, but again, they are alternatives, so they're not as good as doing just a straight up colonoscopy. And patients with a first-degree relative who has colon cancer should be screened via colonoscopy at what age?
Is that like 10 years before their relative had that symptom?
Yeah, so either at the age of 40 or starting 10 years prior to their relative's presentation, whichever one's earlier. And so on a barium enema x-ray, you can see an apple core lesion, as you see in that picture there. Pretty much after you eat an apple and you have the core left over, it kind of looks like someone took a bite out of your colon. So that's a fun little image there for you. Does anyone know what tumor marker can be good for monitoring recurrence of colorectal cancer?
CEA?
Yeah,
That's it. CEA.
CEA, correct. Okay. Any questions on this guy before we move on to Strep bovis? Yep. Okay, so strep bovis. Woo. So, okay, is strep bovis, I'm going to start with simples here. Is it gram-positive or gram-negative?
Gram-positive.
And what shape is it? Between bacilli, cocci, or branching filaments?
Bacilli?
It's going to be cocci. And then is it catalase positive or negative? It's a strep species, so.
Positive.
Positive.
Maybe negative.
Oh, fine. Yeah.
Because catalase positive is the other one, which is staph. And then we have hemolysis. Was it alpha hemolytic, beta hemolytic, or gamma hemolytic?
Gamma.
Yes, gamma hemolytic, which means no hemolysis. And then, does it or does it not grow in a 6.5% sodium chloride solution?
No.
No, correct. It does not. See, we just made it through this chart. Woo! So yeah, so it is a gram-positive cocci, gamma hemolytic, catalase negative, does not grow in sodium chloride solution. Now that we've characterized it, talk a little bit more about it. Strep bovis has a number of biotypes. The one we care about the most is Galolyticus, because this one, biotype 1, is the one that can cause the bacteremia associated with colon cancer. Does anyone know what else it can cause?
Nope.
Anemia? I don't know.
It has something to do with the heart.
Endarterectomy. No, what the hell is it called?
Close. Very close.
Endocarditis?
Yes. It can also cause subacute endocarditis. But most first aid really wants you to hone in on is bovis in the blood equals cancer in the colon. So just know that it's very highly associated with colon cancer, but it's also a very uncommon bug to be infected with. And that is all we have. Oh, actually, we do have some questions. I lied. We have some questions to follow up with. So here's our first one. Of a frail 72-year-old female presents to the emergency department with fatigue, dizziness, and palpitations. She used to eat regularly, but her daughter reports that since her mother was widowed 4 months ago, she frequently skips meals now that she lives alone. When she does eat, her meal consists of small quantities of coffee, rice crackers, and jelly. A blood draw reveals the following results. So your RBCs, 4.3, hemoglobin at 10, and mean corpuscle volume at 105. The patient most likely has a defect in which process? So,
Got anemia, right?
she does have anemia. And her MCV is 105, so is that macrocytic or microcytic?
Macrocytic.
Macrocytic. And she has a very poor diet, lacking in fruits and veggies and all that fun stuff, so...
Yeah, D. D for dog.
D.
Oh, wait. I lied. Hold on.
You sure?
D for
It's
dog?
D for dog.
D is correct.
C is the correct answer.
I didn't even look at C, and I'm like, wait a minute, because I'll get it.
D is correct. So the fatigue, the dizziness, the palpitations, and the low hemoglobin, all of this points to anemia. And then, like we said, with the MCV over 100, that points to a megaloblastic anemia. And we know she's not eating very many greens, so most likely she has a folate deficiency. And B9 is important in transfer of 1 carbon units. So, boom. Nicely done. Do you guys have... Or, no, that's fine. So on to our next question. We have a 37-year-old woman presents to her PCP for management of a genetic condition. Mother was diagnosed with colon cancer at the age of 40 and had a biopsy showing adenocarcinoma as a result of microsatellite instability. Her older brother also had colon cancer at the age of 46. The patient began having yearly colonoscopies at age 30 and has so far not shown signs or symptoms of her family's disease. Given her family's genetic disease, for what other condition is she most likely at risk for, in addition to colon cancer? So we don't really talk about this particular condition, but it is related to colorectal cancer.
B, endometrial cancer.
Correct. So what is her family's genetic disease?
CEA. Oh,
Is that non-polyposis cancer?
Yeah, so it's a hereditary non-polyposis colorectal cancer, also known as Lynch syndrome to make it easier on our lives. So with Lynch syndrome, you have 70% of people developing colorectal cancer, usually between 40 and 45 years of age. And then there's a very high risk of extracolonic cancer, including endometrial, ovarian, urinary tract, small intestine, stomach, and biliary cancer as well.
That's a question that you asked the surgeon, Doctor. Or in AICM, wasn't this the HNPCC, the question that you asked the surgeon? Forget Dr. Lay or whatever his name was. Was it that one, or was it a different one?
That I asked him?
I guess he was asking us a question, and I think this was the answer, because I remember you were the one that answered it. But
No, that was one of the Turcot's FAP.
Oh, okay.
But, yeah, still butt stuff.
FAP will actually be which of these options?
D.
The A.
Soft tissue tumors.
Colon cancer and soft tissue tumors describes Gardner syndrome, which is a subtype of FAP. So.
Well, that's the other subtype. But yeah, okay. You have extranumerary teeth with Gardner's too. Do we have another one?
And that is the end of today.